This patient is a 54-year-old postmenopausal woman who noted a mass in the upper outer quadrant of her right breast. And there was no skin involvement, but it was persistent, and she sought medical attention, where she was noted on physical exam to have about a 4-centimeter mass. It was quite indistinct, on physical exam, clinically no negative, and breast imaging with mammogram and ultrasound showed a little bit over 4 centimeters, about a 4.2 centimeter breast cancer. And on ultrasound of her axilla, she was found to have 2 positive axillary lymph nodes, and one of them was biopsied and clipped, so we knew it was a positive lymph node. The biopsy of the breast mass showed estrogen receptor positive, about 80%, progesterone receptor negative, HER2 3+ by IHC, and it was a grade 3 breast cancer, so a highly proliferative breast cancer. No LVI was seen. She did undergo PET-CT scanning, and there was no evidence of metastatic disease, but the axilla was positive with FDG avid lymph nodes, and her breast was positive as well. So she was otherwise healthy, no particular comorbidities, and she received preoperative therapy with docetaxel, carboplatin, trastuzumab, and pertuzumab, the TCHP regimen, quite standard, along with pegfilgrastim for immune support, and that's every 3 weeks for 6 cycles. And very important to give preoperative therapy so that we really know if someone has developed a pathologic complete response or not, because the therapy in the adjuvant setting is very different depending on if somebody achieves a pathologic complete response or not. So she had an excellent clinical response. She had a clinical complete response. So it was quite encouraging that the therapy was benefiting her. And so she finished her 6 cycles, and then she went to right mastectomy. And she did have residual disease in her breast, about 1 centimeter residual disease in her breast, and 1 positive axillary lymph node. Approximately 4 sentinel lymph nodes were removed, and only 1 was positive. So she did have residual disease. So with that, she's had an excellent response, but she still has residual disease. And we know from the Catherine trial that she will have improvement in her invasive disease-free survival if, instead of continuing on the trastuzumab and pertuzumab, she switches over to TDM1, the antibody drug conjugate. So she did. She received 14 cycles, which is standard, of the TDM1 every 3 weeks in the adjuvant setting, along with an aromatase inhibitor. She received letrozole daily for a plan that would be 10 years, planned 10 years of letrozole, along with post-mastectomy radiation therapy to her chest wall and all the regional lymphatics. So she had that standard of care. So she finished up the now full year of the anti-HER2 based therapy with the trastuzumab. She's doing well on her aromatase inhibitor. So we have another decision point there, and that is whether to consider the addition of the oral pan-HER tyrosine kinase inhibitor neratinib for 1 year per the Extenet trial. It's FDA approved in that context. Particularly beneficial in patients with estrogen receptor positive breast cancer. And so I did recommend that to her because of the substantial impact on invasive disease-free survival in the high-risk population. So we did go ahead with the year of neratinib, continuing her aromatase inhibitor. And she also received IV zoledronic acid per the NCCN guidelines every 6 months, will be a planned 3 to 5 years. So a lot of therapy, but again, a high-risk cancer. So we have a number of very good therapies for her, so we did use them.